So let's talk about, first of all, the lateral femoral cutaneous nerve. Recall that the lateral femoral cutaneous nerve arises from the posterior division of the L2 and L3 nerve roots. So it's wholly a sensory nerve, meaning that it picks up information from the skin out in the lateral thigh region and sends that information up into the central nervous system wrapped up in a nerve that we call the lateral femoral cutaneous nerve. As that nerve approaches the spine, it divides off into two branches. One ascends through the L2 nerve root, the other ascends through the L3 nerve root, bringing information up then into both the L2 and L3 regions of the spine. Now from there, what happens to that sensory information? We haven't yet discussed how that sensory information is then processed either in the spinal cord or up into the brain, but we'll talk about some of the ascending sensory tracts here in a short while. So lateral femoral cutaneous nerve arises from the posterior divisions of the L2 and L3 nerve roots. Now, the lateral femoral cutaneous nerve is primarily sensory, but it also carries sympathetic efferent fibers. Sympathetic efferent fibers. We talked about how those sympathetic efferent fibers below the level of approximately L1 to L2, whichever you consider to be the lowest level of sympathetic outflow, those are mostly postganglionic now, unmyelinated fibers that leave the sympathetic ganglion through the gray ramus communicantes and are now traveling conjoined or together with the general somatic afferent fibers, all collectively wrapped up in a perineurium, which we call the lateral femoral cutaneous nerve. Now, these general somatic efferent fibers, where do they go? They go to somatic structures of the leg. What are the somatic structures? Somatic structures under autonomic control in the leg. Well, they provide for vasomotor, pilomotor, and pseudomotor impulses. In other words, meaning that these general somatic efferent fibers innervate the smooth muscle of blood vessels, smooth muscle of hair follicles, and also innervate the sweat glands in the region of the lateral thigh. Now, according to the AMA guides, and this is on page 551, where it shows the distribution of the lateral femoral cutaneous nerve, the diagram here indicates that the lateral femoral cutaneous nerve arises from the L2 and L3 nerve roots, as we discussed, and it emerges in the pelvis from the lateral border of the psoas major muscle at about the midpoint of the psoas major. So imagine that you're looking looking straight on to the pelvis of a muscled skeleton model. Picture the psoas muscle descending down on both sides of the spine. Well, at the lateral border, at about the midpoint of the psoas, so we're talking somewhere around the level of around L3 to L4, the lateral femoral cutaneous nerve peeks out from the side of the psoas muscle. From there, it continues downward and it crosses the iliacus muscle. And if you remember the iliacus muscle is lining the anterior surface of the iliac crest, the anterior surface, the intrapelvic face of the iliac crest. So lateral femoral cutaneous nerve comes down the iliacus muscle, and it angles towards the anterior superior iliac spine. And then over at the anterior superior iliac spine, it then passes underneath the inguinal ligament and over the sartorius muscle into the thigh. And then from there, it divides into both an anterior and a posterior branch. The anterior branch becomes superficial about 10 centimeters below the inguinal ligament, and from there gives off branches which are distributed to the skin of the anterior and lateral parts of the thigh about as far down as the knee. And then down by the knee, the terminal filaments of this nerve frequently communicate with another nerve, which we'll talk about here shortly, the anterior cutaneous nerve of the femoral nerve, and also with the infrapatellar branch of the saphenous nerve, and forming with them another structure which is known as the peripatellar plexus, which provides for sensation around the kneecap. That's the anterior branch. Then the posterior branch pierces through and becomes superficial at the fascia lata, the wide fascia, the iliotibial band, and then subdivides into filaments, some of which pass backwards across the lateral and posterior surface of the thigh, and supplying from there skin from the level of the greater trochanter to about the middle of the thigh over there on the lateral surface. And for those of you that have the handout materials, I have a diagram here of the lateral femoral cutaneous nerve, which shows that the nerve becomes superficial right as it passes underneath the inguinal ligament at the ASIS, and from there divides into anterior and posterior branches. And the anterior branch, as the name suggests, provides for sensation down the anterolateral thigh about as low as the knee, where it forms the peripatellar plexus. And then the posterior division provides for sensation slightly more laterally, about as high as the level of the greater trochanter, down the iliotibial band to a region just a couple of inches above the knee on the lateral aspect of the knee. So where can this nerve be pinched? Well, the nerve can be pinched or damaged or compressed or entrapped at the spine. First of all, at the spine level, at the levels of the L2 and L3 vertebra, where those nerve roots come out. For example, due to disc lesions, for example, due to hypertrophic arthritis of the lumbar spine, or any condition of the spine can result in nerve root compression. At the psoas muscle, because the nerve arises or emerges from the lateral border of the psoas, and because the psoas is wrapped in tight connective tissue, the nerve can be affected by an abscess of the psoas muscle, an inflammatory abscess, perhaps secondary to an infection. That can cause space-occupying compromise of the nerve as it passes and peeks out from the lateral border of the psoas. So that's another site where the nerve can be damaged. At the inguinal ligament, the nerve can be damaged, and there's several different causes or situations that cause injury and damage to the nerve at the inguinal ligament, one of which is due to traction neuritis, or an excessive or repetitive pulling on the nerve as it passes underneath the inguinal ligament. This can cause stretching and even angulation of the nerve as the examinee or person or patient, in this case we'll call it examinee, moves from a sitting to a standing position. And this is known as the condition of neuralgia paresthetica, which is caused by a traction neuritis as the nerve passes underneath the inguinal ligament. Now, also, because the nerve is superficial, as it emerges underneath the inguinal ligament, local trauma in this area, such as from wearing a tool belt, such as from sitting with the knee higher than the hip, such as wearing tight work pants that grip tightly around the anterior superior iliac spine. These factors can cause local trauma and compression of the nerve as it peeks out from underneath the inguinal ligament. Also, pendulous abdomen, or the use of a brace, or the use of a corset, or anything that causes compression and or traction down across the lower part of the abdomen are risk factors. And the populations susceptible to this traction neuritis or local trauma include those with large pendulous abdomen, such as those who are in the late stages of pregnancy, those who have recently gained a lot of weight, typically found in the so-called beer belly type of syndrome, where the belly hangs over low and tight pants, which are supported by a very tightly fitting belt. Those several factors conspire to compress or stretch the lateral femoral cutaneous nerve at the inguinal ligament. Okay, so with neuralgia paresthetica, some of the signs that you're going to see, or that the examinee is going to complain of, includes numbness, tingling, burning, or hypersensitivity over the anterolateral thigh. And many times this tingling or burning or hypersensitivity or the numbness goes unnoticed, and it finally becomes noticed when the person, the examinee, puts their hands in their pockets or carries keys in their pockets. It's only by brushing their hands up and down their thighs as they bring their hand in and out of their pockets that they realize that the sensation on the lateral thigh might be diminished or even numb. And I don't know if you've ever had, any of you listening to this program have ever had an injury to the lateral femoral cutaneous nerve, but I myself have. And it goes back to an injury that I had riding dirt bike motorcycles about 5 or 8 or maybe even 10 years ago now. I was riding some motocross on a motocross track, and I was going as fast as I could, and I was doing pretty good, when all of a sudden I came over a jump, and on the other side of a jump was a little kid who for some reason was riding his motorcycle across the track in an area out of vision of approaching vehicles, which in this case I was the approaching vehicle. So as I landed after coming over this jump, I saw this kid crossing the track, and in order to avoid hitting him, I slammed on my brakes and got sideways, and eventually got thrown off the motorcycle over the front of the motorcycle. And as I went over the front of the motorcycle, my right thigh struck the handlebar very hard. So hard, in fact, that I couldn't walk. My thigh I had such a contusion on my thigh, and there was so much pain in the thigh that I couldn't bear any weight on my thigh. So over the course of several weeks, after the strength came back in my thigh, I noticed that my thigh, the skin on the surface of my thigh, was numb. And it's still numb to this day. And that's known as neuralgia paresthetica. It's due to, in my case, there was a direct trauma as the handlebar hit what I believe to be the posterior branch of the lateral femoral cutaneous nerve. So I don't know if you've ever had that, but fortunately the lateral femoral cutaneous nerve is only a sensory nerve. It doesn't control any motor function, so I've been able to enjoy full strength again of my quadriceps. And I'm also much more careful about going over jumps nowadays and around hidden corners. Okay, so let's review this. So with the lateral femoral cutaneous nerve, if this nerve is injured high up in the spine, for example in the region of the L2 and L3 nerve roots, what kind of physical exam findings might we see? Well, in the case of a herniated disc or osteoarthritis of the upper lumbar spine, or anything that affects the nerve root level, the L2 or L3 nerve root level, we may see weakness and atrophy of the quadricep muscle. And the reason we may see weakness and atrophy of the quadricep muscle is because high lesions affect the L2 and or L3 nerve roots. And as we're going to see in a couple minutes when we talk about the femoral nerve, the L2 and L3 nerve roots contribute to the femoral nerve. So therefore a lesion high in the spine that affects the L2 and L3 nerve roots may also cause simultaneous findings in the quadriceps, maybe weakness and atrophy of the quadricep muscles. However, even though the quadriceps may be involved, it's most likely that the patellar reflex would be preserved. How can that be? Well, the reason that can be is because the patellar reflex is almost entirely and purely a function of the L4 nerve root. And so as long as L4 nerve root is unaffected, the patellar reflex would be preserved. Now, if the lateral femoral cutaneous nerve is entrapped at either the psoas or the inguinal ligament after the L2 and L3 nerve roots come together to then form the named nerve, the lateral femoral cutaneous nerve, then we're going to have sensory findings only. There will be no motor findings, because by now, once we get to the lateral femoral cutaneous nerve, there are no motor neurons traveling in this nerve. So the only physical exam finding that we would expect would be some sort of dysesthesia, either numbness or tingling or burning or heat or some sort of altered sensation to light touch and or stroking over the anterolateral thigh. And even though you might not think it's a big deal to have dysesthesia at the lateral thigh, the AMA guides do provide for permanent impairment due to permanent dysesthesia due to injury to the lateral femoral cutaneous nerve. And we'll talk about that when we get into our discussion of the AMA guides.